Welcome, and thank you for attending today's Healthcare IT News webinar, Outcomes-Based Contracting, Empowering Providers to Create Tailwinds During Paradigm Shift, sponsored by CO Health Analytics. My name is Bill Sawicki, Managing Editor of Healthcare IT News, and I will serve as moderator today. We look forward to your questions and comments, which you can submit at any time by accessing the question box on your screen. We will make every effort to answer your questions during the presentation's live Q&A. Throughout this webinar, attendees will learn key considerations to know and understand during the current outcomes-based paradigm shift, hear about the importance of reliable, pristine data to risk-based outcomes, understand how to use advanced analytics to mitigate clinical and financial risk, learn the importance of having the right data to create a patient-level view, and see key areas in which predictive and prescriptive analytics can help providers focus on high-value opportunities that improve patient outcomes. Our speakers for today's webinar are Dave Hom, Chief Evangelist at CO Health Analytics, and Dr. Kevin Keck, Chief Medical Officer at CO Health Analytics. Without further ado, I'll hand it over to Dave to begin the presentation.
Thanks very much, Bill. The agenda today is as follows, is really understanding, are there headwinds that providers are facing in 2018 and 19? And then how to think about convert those headwinds into tailwinds to create a competitive advantage. And it's all through the lens of value-based contracting, things that you need to consider, things that you need to be thoughtful of, and things that you need to think about in terms of implementing these types of programs. And the core of all this resides really in the data. Data within the health systems are highly fragmented. The question becomes is how do you align the value of it, how do you align different data sets to create value for providers, particularly around patients and patient risk. And then we'll talk a little bit about advanced analytics, which is how do we begin to create more predictive value that integrates clinical data to financial data that's typically used by health plans. How do you then look at populations in its totality and stratifying the risk and then aligning resources for those risks that are both current and also prospective. And last is then how do you align the network that a health plan has to the different risk populations to ensure that there is continuity between risk of the member to the providers that are the most efficient in providing care for those types of services. We'll then go to some use cases and summarize it in a Q&A. So that's the agenda today. So this concept of headwinds is interesting. Is everyone hears a lot about, we've got these emerging costs that we're facing, and so how do we begin addressing those? So everyone's beginning to think about pay for outcomes, whether it's CMS, whether it's a health plan, whether it's their employer. They're asking, am I getting value for the dollars I spend today? How do I measure the value of those dollars? And then does it improve the health of the population, leading to things like improvements in productivity, defined as absenteeism and presenteeism? Then tailwinds are the interventions that we're recommending for the patient impact the risk, and then what's the value of those interventions? Compliance. People always talk about compliance, and what that speaks to is, will the patients really understand what they're supposed to be doing, the value of those different services, whether they're medications, whether they're office visits, whether they're labs, and are they getting them done in the appropriate time frames? And then it's all these services, whether they're devices or they're physician services, hospital services, are there outcomes that come out of using specific types of services and how we measure those? And lastly is how, as a provider, how do I begin thinking about both clinical risk and financial risk? Because as a provider, my lens is always clinical and it's episodic. The patient comes in, I deal with the patient's issues, but do I truly understand things that are impacting their total healthcare costs, including items like behavioral health, psych and substance abuse, issues dealing with their family members that impact how they think about their own chronic conditions. So now I'm going to turn this over to Kevin.
Sure. Thank you, Dave. We're going to talk about key considerations for value-based contract design. And there's fundamental building blocks that are important to make this successful. And the triple aim is the three-legged stool of appropriate cost, appropriate quality, and appropriate patient experience for the service given. To change behavior of physicians or hospitals to get to the triple aim, there are these building blocks. The goal needs to be, we're going to improve quality, and we're going to make this better for the patient. And by the way, costs will go down when that happens. To change the physician behavior, there needs to be significant compensation plan realignment, and that's both for employed and non-employed physicians. And what this looks like is if the bonus, if you will, is $1,000 a year, then the value-based contract needs to be designed so that the physician does about 4 hours of work to gain the $1,000. That's not much, but it is a start. On the other side of the spectrum is our compensation plans that look like 40% of practice income. And the larger the alignment with the compensation, the more behavior change there's going to be. Now, the compensation models need to be adaptable over time. They're not fluid, but they need to have the ability to expand, to subtract elements, to increase the bar over time. They need to be valuable to providers. Now, MACRA, which is rolled out this year, has 60 some odd measurements. If the provider has chosen some MACRA measurements, then a value-based contract on the commercial side would be helpful to the provider. The measurements need to be easy to understand and easy to measure. So in going to the physician network, there will be skepticism, although CMS has helped with its changing compensation to value-based. So the resistance is being addressed. Also, the strategy needs to be so simple that it can be explained by physician leaders, by colleagues in the office, by the charge nurse, by the hospital administrator, by the vice president of medical affairs. It needs to be explainable and understandable. So saying, for example, that let's make sure that our lung cancer patients live 2 years if we treat them, that's very complicated. If instead let's focus on ionizing radiation on diagnostic imaging of the brain, that's very understandable. And that example might be used if there's an issue with high-tech imaging in the local situation. The physicians need to agree and understand the methods of measurement. The starting point is very simple. I've done starting points in the past where the physicians or the hospital gets the bonus or the change in conversion factor just for sitting down and looking at the data, not caring what the data came out, but just that they would look at the data. So something very simple that gets the physicians interested. Yes, this is a good thing. All you have to do is look at the data this year. Okay, fine. And once it gets started, then more thresholds can be put in. When the data go to the field, it has to be pristine, and all data points will be questioned. And here's a story of a physician who had a goal of LDL cholesterol less than 100 in the appropriate cohort. The physician was pointed out to me that the cholesterol was 102, and that was out of compliance. So things like that will happen, and it's not a good situation if you can't explain what the data show and why it was obtained, so that the physicians are very critical. What they want is for these outcome data to be in the realm of medical literature or their electronic health record. So it needs to be as precise as possible. The data needs to come from claims, electronic health record, socioeconomic. As much data as can be layered in will help determine what the measurements are and what the goals should be. And lastly, it needs the data need to deliver insights to providers. So if the provider is taking risk and they're in the alternative payment model and they want to look at the total cost of care, then the measurements that you choose as shown by data will have an impact on the quality and therefore the bottom line. So it's more important, for example, to manage diabetics to a hemoglobin A1C, which is around 7, than to say, if a patient has sinusitis, then we won't give antibiotics for 10 days. One of those measurements will have a direct impact on the bottom line, and therefore more bonus for the physicians. The antibiotics in sinusitis is problematic for a couple of reasons. One is the numerator is never 0, and the physicians always are upset that, why am I being penalized because my numerator is not 0? So you have to choose the measurements so that there will be an upside for the physicians that they can understand. And so they'll know where to push and what gaps in care they want to manage. So, Dave? Dave?
Thanks, Kevin. And now we're going to shift over to this concept of in the data, what's meaningful, because there's thousands of data sets. How do you identify what's of value to create a patient view aligned to a physician view? And then how do you data layer the different data sets in what sequence to create both a financial risk and a clinical risk? So data layering becomes critical. And then how do you measure the value of the outputs for both the patient and the physician in their journey around value-based payments? The reason why I think this is important is, and what Kevin talks about in terms of making it simple, making it iterative for physicians, is because Kevin, before he joined CO 4+ years ago, worked for a large regional health plan and a large regional health system where both of those engagements, Kevin was asked to turn it around, and he did it through this concept around value-based payments and value-based contracting and lessons learned. So what I'm going to do now is bring you through the form of art around how do we think through holistically everything around the patient's ability to understand, comprehend, the care gaps, patient's ability to close those care gaps, whether they're economic, whether they're geographic differences. Can I get to the doc? Can I get to the pharmacy? Well, to literacy as to whether I truly understand what these gaps mean. Then also aligned to physicians in terms of, does the physician understand when they reach a patient and their care gaps, which care gap has the greatest value to close, because people can't remember 8 or 9 things. And so what's the 1, 2 things I want to say to the patient that can reduce avoidable inpatient, avoidable ER visits, readmissions, and also extended length of stay, which has a significant impact to the risk-bearing entity. So what we look at is the following. And this is a view that we think is an ongoing view of today. People use claims data. That's from medical, RX. In the claim files, the eligibility data set. So it's got member data, age, it's got the address, and so there's information there that's highly valuable. Lab data is now coming in to more fruition in terms of the actual lab values versus the claims. So Kevin talked about this notion of the HbA1c. Well, we know that in some of the what we call prioritization logic or trumping logic that we've created, if a person has a HbA1c score of 6.4, the health plan or health system would declare them as a non-diabetic. But if you look at a fasting sugar level test where the results are 128 or greater, so now my value is at 140, that logic should trump the HbA1c test score to 6.4 and identify me as a diabetic. So that's the value of labs, and you add in things like blood pressure readings, cholesterol readings, BMIs. You then have to figure out what's the prioritization logic of each of the different lab values on predicting events such as cardiovascular events, such as joint pain, etc., where those lab values have value. Fitness data is becoming more in vogue and being able to be captured by many different types of systems, whether they're Bluetooth to your laptop or your phone. It captures not only the duration of the exercise, but more importantly, we know in the data, what's really important is the intensity of the workout. And so it's the heart rates after 30 minutes. That has significant value in measuring the impact on things like diabetes and hypertension. RX is always important because it measures compliance. It also measures risk and dosing levels. Socioeconomic data is something that we believe is critical. And what that says is at the patient level, take home, it has my income, has my address, and within that household level income, it also has how many dependents do I have. I have 2 kids. I have a spouse. It also has my educational level. It also has things that I spend my money on in terms of goods and services and types of foods that I buy. That has significant value because that measures doability of myself in accomplishing that goal. So if the test costs $100 a month, or the lab value costs $100 a month, or the drug costs $100 a month, and I'm in a moderate income household, I live in New York City, doability of closing that gap becomes low. Then also, we've also done some analytics around, based on the household, is it actually doable for me to get to the drugstore for medication compliance? So if I'm a retiree, I'm in a Medicare Advantage plan. I live in Florida. To make 2 left-hand turns from my house onto Highway 41 is very difficult, therefore not doable. So left-hand turns for retirees because of fare is a barrier. Then within the EMR, it's always, there's a lot of data in the EMR. And the question becomes is, what data has value? What data is used for providers? So by capturing key lab values and EMR values, coding for CMS patients can be validated. Also for exchange populations, for risk factors, EMR data can be pulled and extracted to enhance the patient profile. And then the new world of devices. So here's how we think about the business is what's the total cost of care? And that's both inpatient, ambulatory services, but also if they're in care management programs for the health plan, if they're in a care program that an employer sponsors that they're utilizing, that's also the total cost of care. What's the member's risk without claims data? So can you do something without claims? With claims, are there financial risks that we can predict? So now create enhancements or data layering. And then it's, can we become more predictive? Can we enhance our prediction values? Can we use lab values to predict higher financial risk or make it more pristine in terms of predictability? Data from the EMR creates more pristineness around enhancements of risk. And then looking at data to look for compliance, probabilities of patients to be compliant, non-compliant, predicting them upfront in advance. And then how do you intervene with those people that you predict to be non-compliant? The data health should be updated, refreshed, because what you want to do is have a dynamic view of the patient on an ongoing basis. And then is the data right? You know, it's intuitive. Does it make common sense? You know, and then how do we reduce false positives? All this what called journey of data. It says, will the patient be compliant? There's little data. When there's more data, medical RX, and what's the increased value? And you add in more data like fitness and socioeconomic data and then EMR data and device data, does it create more predicting enhancements? Then also, can it become more prescriptive at the patient level? And so the doctor then says, for these patients, these are the things that I need to talk to them about when they come to see me. And that becomes critical in the new world of outcomes-based contracting. So I want to spend a little bit of time on this just to give a sense of what I call breadth. And this is all about data layering. So you can look at behaviors, attitudes, demographics, and it all comes down to clinical factors, cost, quality, but also around risk. So we think that these analytics have value to the provider. Providers prescribe certain patterns of services for patients. Are they the right patterns? So, for example, a lot of if your plan design says that Dave's entitled to 12 physical therapy services, no matter what risk I have, all those patients get 12 services. And maybe some patients should get 15, and others should get 6, depending on their types of risks. So we need to be thinking about the provider's prescribing patterns and their profiles to the patient member profile and risk. So this is the way we think, and this is the way our customers think, which is a lot of data. I'm a doc. I'm a hospital system. I understand this claims data somewhat. I think it's okay. I use it mostly for billing. And what we say is, well, these data sets have fundamentally sound value, but when you begin tying it to other data sets and clinical data sets, you begin to create an enhanced view of the patient, that the doctor can then understand, are the things that, that I can do. So for, things like weather patterns, changing weather patterns has different impacts on people's compliance. The economy in the local area, each economy acts differently, and it has behavior, and it has impacted people's behaviors. Are they feeling good about themselves? Are they feeling good about their income? And that is always viewed as a strong marker for compliance. So you begin looking at all of this data, and you begin to say, how do I harmonize it? How do I identify what data has value as you layer? Then how do I use this for outcomes-based contracting, understanding the patient, to become more predictive, but also prescriptive to define what service do I want to tell my patient to do when I reach them. So with that, I'm going to turn it back over to Kevin.
Okay, thank you, Dave. We're going to talk about how analytics can be applied to mitigate clinical and financial risk to improve overall population health. And we'll also touch on network optimization. Let me go to the next slide here and show you the CO journey into advanced analytics. And as I describe this, think about the healthcare dollar, including inpatient elective surgery, inpatient medical, OB, skilled nursing, ED, and outpatient surgery, which is about half of the healthcare dollar. And these tools directly impact that. There's other tools to impact specifically pharmacy, specialty pharmacy, and X-ray that gets you up to 3/4 of the healthcare dollar. And there's analytics to address those. But our story is starting with the startup of the company using predictive analytics as opposed to retrospective analytics. And when I started with population health, it was just a guess who's going to be sick this next year. How do I manage that? And the first breakthrough was being able to predict risk of the patient going forward. Next, the concept of behavioral economics was developed. What this looks like is if the patient has 17 chronic conditions, the therapy of that patient or the treatment of that patient is to get them educated, motivated, and empowered to take care of themselves. And in chronic conditions, a major pathway is getting the medications taken on a routine basis, seeing the doctor, getting the laboratory tests. So an example of behavioral economics is this, that if you find in your analytics that there is a substantial spend in hypertension, which there is a choice for a set of antihypertensive medications to be not only on first tier in the drug benefit, but zero copay or $1 copay. That's an example. So same thing with diabetes. Metformin, when prescribed, costs $1 for a 30-day supply, as opposed to $5 or $10 for a 30-day supply. And these behavioral economics have been measured to reduce hospital events and healthcare improvements. Similarly, in the area of elective surgical inpatient, there is what we call gray zone medicine or preference sensitive conditions. An example is total knee repair. The patient has a degenerated knee, and the physician says, I think you need a knee replacement. And the indications are subjective in this area. So being able to identify those services, and they're mainly surgical services, where the benefit is gray zone. The patient is not always helped, is another way to say it. being able to identify that and manage it becomes an opportunity because of these analytics. Then the next advance was, well, if a patient is on a pathway to get a spine surgery, can we see it coming? And the answer is yes. And if we can see it coming, then the intervention is to work with the patient after identified to get to a medical back clinic and to avoid spine surgery. That's an example of that. The next advance was in looking at prescriptive risks. In other words, the patient has predictive risk of whether they're going to be sick, and prescriptive is why they're going to be sick. And we call that gaps in care. And if, for example, a patient has high blood pressure or hyperlipidemia, and it's found that the 80% medicine possession ratio is not met, then that is a gap in care. And once the gaps are identified through regression analyses, we can say by closing this gap, we expect this much savings. By closing that gap, we expect this much savings. We have expanded into Medicaid, and we also have analytics now which look at claims audit. That's a 3% or 5% opportunity from fraud, waste, and abuse. Also, in HCC coding, claims management will increase top-line revenue. So that's our story, and we are continuing to innovate to get better and different analytics to enhance the ability of the risk-taking entity to do population health. Now, in looking at how this ticks and ties back to provider-based contracting, if I am the risk taker or if I am getting the contract, I want to ask the question, where can I have the greatest impact? There is an answer to that. And like I used the example of, it's more impactful to manage diabetes well than to manage sinusitis well. The analytics will show what is the impact of this intervention. I'm using an extreme here, but it is a gray scale. What conditions and subsequent interventions represent the highest opportunity value? Who is at risk to undergo an avoidable elective surgery? Which consumer types comprise my membership? Are they baby boomers? Are they millennials? Do they get their healthcare information off the smartphone? Do they see the doctor and follow what the doctor says? Are they cost conscious? Are they not cost conscious? Knowing the type of patient will enable the risk-taking provider in the risk-based contract to manage the baby boomer, the millennial, the lower socioeconomic, poorly educated, appropriately to get quality improvements and therefore an improvement in bottom line and a happier patient. And last but not least, we need to be able to drill down to the member-patient level. You need to know where to push to get your outcome. So these are the types of analytics that are necessary for a successful risk-based contract. Now, this is a slide that shows where to push. And when there is an intervention, suppose I am an ACO, or suppose I am a hospital system, or suppose I am the contractor, I want to know which members do I intervene with and how to get a measured outcome. So what we can show with our analytics, analytics should show, is breaking the population down into risk buckets of impactability. And a high impactability, moderate impactability, and low impactability. An example of high impactability would be a patient with high blood pressure who's had a stroke. and is now not taking their blood pressure medication, or a patient that's had a myocardial infarction that is not taking their statin. So that's high impactability. And the number of gaps in care also will equate to high impactability. Low impactability would be an example of that would be a patient who has high blood pressure and hyperlipidemia, and the medicine possession ratio is 80% for both drugs. That's a low impactable patient. So the attention is turned to the high impactability patient. You then can look at what is the prospective risk of this split cohort. And with this added cut, then the sweet spots can be found. We take the sickest 1%, 19% of the healthcare spend right off the top, because they likely will need some kind of case and disease management, but they can be looked at as an individual. The next 5-6% again will comprise 70% of the healthcare spend. You look at high impactability and high risk. Those two together is a major sweet spot. And so by looking at the high impactability, 12% of members, and then the high risk among them, that's now 1.2% of members, a concentrated program working with this cohort will yield results. And each of these buckets can have an outcome attached to it analytically. I can tell you that when the patient has high impactability and high risk, that is the major sweet spot. High impactability, moderate risk is a next major sweet spot. And then moderate impactability, high risk, even less than above. But one wants to tailor the resources and effort to what the outcome is going to be. I'm going to move on here, and this is another way to look at what conditions and interventions will deliver the greatest value. We call this a bubble chart, and it shows various chronic conditions. Those are the bubbles. The y-axis shows the impactability of the condition using value-based benefit design. So if the patient has high blood pressure or a statin, a value-based benefit design would have a high impact or a higher impact. And then similarly, the x-axis, or in contrast, the x-axis shows the effort with the intervention. The lowest effort is on the left side. The highest effort is towards the right. And the interventions can be then tailored to where the chronic condition fits. And we're pointing out the red bubble. It could be high blood pressure. It could be high risk OB. It could be high-tech imaging. It could be seizures. It could be Parkinson's. The bubble chart will show you this is the opportunity by number of patients, number of dollars, and this is the effect of benefit design, and this is where it fits in the effort of management. This next slide looks at who is at risk to undergo avoidable procedures, and think of joint replacements. It's interesting that MACRA is focusing on joint replacements and end of life with oncology. I used to think that CMS was primitive in its understanding. After Medicare Part D, I respect what CMS comes out with, and they're looking at this as we are representing it. But in a preference-sensitive condition, total knee repair, we now know that patients scheduled to go to total knee repair when put into two separate cohorts, medical versus surgical, they can change from medical to surgical at any point. About 1/3 of patients scheduled for knee surgery did not have it after 1 year. and the intervention was shoe lifts and physical therapy. So knowing that a patient is at risk for a knee surgery by finding claims for x-ray of the knee, MRI of the knee, physical therapy, knee brace, diagnostic knee arthroscopy, by finding those upstream markers, we can tell who is at risk for a knee repair or a spinal surgery or a hip repair, and then an intervention can be proposed besides surgical therapy. And then who is at risk to undergo avoidable procedures? Again, this is a slice and dice looking at patient risk and which conditions are impactable. It turns out our analytics show that the medium risk patient is the most impactable in most of these. And you can see that, like low back pain, 14 have high risk, 12, I'm at the bottom of the slide, 12, 13 have medium risk. The bigger impact are the medium risk cohort. I'm going to turn this over now to Dave.
Thank you, Kevin. I think what was important, what Kevin talked about, was by using data, and it comes in different shapes and sizes. We've had the ability to qualify patients risk, and then quantify patient risk to outcomes-based contracting. So think about it as the alignment between both the patient risk, doability, and the physician's prescribing patterns. What this next section really begins to talk about is how do you use analytics where there's a little data and then more data. So in this consumer segmentation analytics, it's looking at just demographic data. So it's Dave Hom, it's got my age, it's got my income, it's got my number of dependents, where I live, and it takes in those types of data sets. And what we've done is said, based on these types of profiles, so I'm a older chronic patient, what types of risk do I bring to the health plan or health system when there's little data? So I don't use the healthcare system, but I tend to be more prone for certain chronic conditions because I'm older, I'm Asian, and I'm a male, and therefore there's some propensity models. So what we've done is created this approach of using segmentation, consumer data, but then adjusting the consumer data for clinical risk using some of our claims. And so what this looks at is, and these are just what I call broad strokes of young, healthy, balanced adults to quality-driven, cost-conscious, high-cost baby boomers. The thing that was interesting in the young healthies was this was a surprise. When we loaded our benchmark database, we said, yes, they have low risk, low inpatient utilization, but the ER utilization was greater than expected. And we said, wow, that's a surprise. And when we went into the diagnosis codes for the ER admission, the ED admission, it was driven by falls, injuries, and accidents. So it's a very active group, runners, bikers, swimmers, where they get injured over the weekend, and then there's a trip to the emergency room. So then the question is, are there other avenues the person can use? And the answer is yes. There's urgent care, there's telemedicine that are as equally as effective in managing those types of situations. So this gives you by types of person, types of utilization, and so then when you get a new group coming into your provider group or your health plan, you can assign these people to different what I call personas, likelihood for certain conditions, but also likelihood for being compliant or non-compliant. And so now you have a thesis around the patient. And this is a little bit about some of the segments. You could see demographic above the poverty level, blue collar, ER utilization, age, gender, income levels. And this is also, it's got preferred mode of communications. and this is based on a lot of consumer research. And what we do with that is we say Dave likes to get regular mail, but in fact he only likes to respond to text. Therefore, we adjust the channel preferences based on Dave's preferred mode of communications. And then this goes back to Kevin's point of who. So once we identify, the patient, we've identified, the care gaps. Kevin and I are same age, same conditions, but Kevin has 6 care gaps, and I've got none. But I've had a prior hospital event. Most systems will make me higher risk than Kevin. In reality, all the Kevins in the world have a similar risk profile than Dave, and therefore should be included in outreach. So we predict inpatient probability in ER probability. So highly predictive of inpatient and ER events. And then we take, and this is a refined predictive value called the Pathability Score. So now we segment the population back to the concept that Kevin raised in segmentation. We then identify for each patient which care gap is 1, 2, and 3. So this prioritization logic of care gaps becomes important to create what I call consistency in outreach. And this is more specifics. This is 56-year-old male. These are the conditions. These are the care gaps. Probability for inpatient visits are high. Probability for ER visits are high. Estimated cost. Estimated reductions in reducing probabilities and creating cost savings to avoid those types of events. This is an example using real data. So in summary, we've got the whole industry is facing headwinds. Whether the macro headwinds that Kevin talked about, which is fee-for-service Medicare changes, whether there are increased out-of-pocket expenses for commercial members to high deductible plans, whether there's increased Medicaid participation, or whether there's increased flow or changes in the people in the exchanges. Those are all headwinds that providers are facing. And so the question is and all the health plans are driving towards this outcomes-based contracting, and then it's how do you structure a process? Again, it's a process of how do you align the incentives of payers and providers to drive better what I call outcomes in the AAA, and then understanding clinical risk and financial risk, and then making the data more pristine, knowing that data today is still very dirty, very cumbersome, but over time it will get better to make what I call an outcomes-based contracted work more effectively. And then how do you create more prescriptive analytics? Everyone struggles with, well, I can do a lot of predictive analytics, yes, but can you do it at the patient level and provider level in terms of what things create action? Is it doable by the patient? And then if the patient accomplishes that service, what's the ROI? So again, qualify the patient, quantify the program, and measure the program from a financial perspective. With that, I'll give it back to Eric and or Bill.
Very good. Thanks so much to our speakers for that very informative presentation. We do have time for a few questions from the audience, so let's begin. Our first question is, can you talk about care gaps versus chronic condition management and how providers should think about focusing resources?
Let me start with that. In managing a chronic population, the goal is to educate, motivate, and empower. It's those three things. And you use motivational interviewing to get the patient energized. Now, if there is a care gap with the patient with a chronic condition, then that patient's name should come up to the top of the list. For example, if you're managing end-stage renal disease, These are patients on dialysis, very expensive patients, very few in the network. They don't survive is what happens, but they can have a good quality of life for the years that they have. If a patient has high blood pressure and end-stage renal disease, they have hypercholesterolemia and end-stage renal disease, and there's gaps in care with their medication possession, then they need to come to the top of the list. In the example I'm giving, then every patient with end-stage renal disease should be managed. Now, let's go to the other end of the spectrum and take asthma. And asthma is managed by the patient having possession, education, motivation, and empowerment. And the patient needs possession of two medications. One is a controller, and then the second is an acute rescue inhaler, and that's albuterol. In managing the asthma population, it is not prudent to manage all because there's too many patients with asthma. So you use the gaps in care with the chronic condition to tell you where to focus. And so with this model, if you take a high-risk patient and you notice that they don't have a controller medication, that is a chronic patient with a gap in care, with high risk, that patient should be managed. The other side would be a patient with asthma, has not been to the ED, has a controller, has a rescue inhaler. That patient can be managed, if you wish, with push notifications on the cell phone. So that's how you use gaps to prioritize how you manage the chronic conditions.
Very good. Our next question. Are you seeing any best practices from providers in breaking down the data silos, specifically related to the challenges of integrating clinical and claims data?
Yes, so and the answer is yes, and it's really a journey. So we have two of our largest customers, and these are large health systems, have asked us to, can we integrate data for a specific population, Medicaid? Two is, can we create a patient profile, and can we measure risk of those patients that are in Medicaid because of the nature of the movement of Medicaid people in and out of Medicaid is difficult to manage. And then what conditions do we want to focus in on? So the answer was asthma, particularly for children, pregnancy, particularly for young adults, 15, 14, 15 years old. And three is diabetics for the older Medicaid populations. This excludes the dual eligible.
Okay,
so the health systems are now beginning to join the journey of using data to create specific measurements for their populations. Sorry, Bill.
Okay, our next question. Do you see providers using analytics to manage total cost of care?
Kevin?
Yeah, I see that coming. And remember at the beginning of our presentation, I talked about the gentleness in choosing the measured parameters in the contracts. And, when I started doing performance-based contracting 15 years ago, there was a lot of skepticism and resistance by the doctor. I don't want to have to do this stuff. Just pay me my conversion factor times my RVUs. However, since CMS is now saying that this is how we're going to pay you on title programs for outcomes-based contracting, putting 4% on it or so, then physicians are coming around. And if the physicians have size and they can take risk contracts, yes, then they're very interested in managing the total population. This is an evolution. When you've seen one health system, you've seen one health system. There's a spectrum, but it's moving toward managing the total cost of care.
Okay, that's all the time we have for questions today. Please be sure to complete the evaluation and share your thoughts with us. I'd like to thank our speakers for taking the time to share their expertise with us. Today's session will be available on demand until November 3rd. Thank you very much and have a wonderful day.